Hello everyone, I'm Dong-In Seo. I'm an associate professor in Department of Pediatrics in Seoul National University College of Medicine. I'm really honored to have a brief talk on the phenotypes and endotypes of pediatric asthma. This concept of endophenotype has recently been highlighted and not many theories are established until now, but it has been widely studied for adult severe asthma that are refractory to the current stepwise management. Just one thing you have to keep in mind that these approaches are for personalized management as known as a part of the precision medicine. So let's begin. On the issue of conflict of interest, I have nothing to declare. Today, I'm gonna tell you the phenotypic and endotypic approach for the pediatric asthma. More precisely speaking, I will first introduce the phenotypic approach for heterogeneous disease. Then I will show you several non-asthma phenotypes. Thereafter, I will briefly introduce you the endotyping based on the asthma pathophysiology. The status for phenotypes of Korean pediatric asthma is then followed. Finally, I will wrap up the presentation with telling you the implication of the endophenotyping and the future perspectives. Now, let's begin. The fact that asthma is not a single disease, but rather an umbrella term diagnosis, that is, a combination of various diseases, confuses researchers who should decide the treatment strategy and predict the prognosis. In such circumstances, a phenotypic approach is useful for systematically viewing a group of diseases that is essentially heterogeneous and is practical for determining therapeutic options most appropriate for each individual and predicting the prognosis. Let's refer to a similar situation for the Mendel has encountered more than 100 years ago. We can see various characteristics of the pea plants. Their seeds are various, flowers are different, form and color of pods look different. He gathered information regarding these determinants and finally suggested the law that finally affect the phenotype of pea plants. During the process, appropriate phenotyping is the basic and critically important step because it may help us to figure out the pathophysiology underlying this phenomenon. There are various ways to clustering heterogeneous population. We can use several criteria by which we can determine to include each subject. In the example 1, bolding outline is the main criterion to determine subject groups. In the example 2, the shape is the main criterion to divide groups. Finally, in the example 3, similar colors are the main criterion. Likewise, we can classify various asthmatic children into several phenotypes by classifying clinically observable features regarding them as results of the interaction between an individual's predisposition and environment. Now let's see what sort of asthma phenotypes have been reported. Phenotypic classification of pediatric asthma began with the analysis of the cohort studies. Based on the epidemiological data and complaining symptoms, researchers found several characteristics as risk factors of asthma persistence. Among them, the onset timing and the persistence of asthma symptoms is historical and practical. This figure is derived from the Tucson Children's Respiratory Study. At this time of 3 and 6 years, the wheezing history and persistence is assessed. Based on the information, 4 wheezing phenotypes were reported: transient early, early persistent, late onset, and the last one. After we divide wheezing groups, later we come to know that each phenotype has different characteristics. Transient early wheezers has lower lung function at birth. early persistent features are non-atopic and had BHR at birth. Late onset features have atopy with BHR and they are IgE associated. Finally, the last one has OBEs with early menarche. Then what can become determinants of the asthma phenotypes? In the previous slide, the onset and persistence of symptoms played as determinants. Other clinical observable features can act as determinants. Besides the onset and symptoms, gender, medications, exacerbations, lung function decline, and BHR can be determinants. Most of all, various markers for atopy can be a good candidate for determining asthma phenotypes. Precipitating factors can be good determinants for clustering phenotypes. In this flow chart, asthma phenotyping algorithm adopted the precipitating factor as determinants of asthma phenotypes. Viral infection or exercise can play the most common precipitating factor regardless of allergic sensitization and can form a specific asthma phenotype. When subjects are followed up regularly, their longitudinal course of wheezing can be analyzed by an unbiased longitudinal latent class analysis. As you may see in the figure, there exist similar but slightly different wheezing phenotypes. In addition to the classical 4 wheezing phenotypes, intermediate and prolonged early phenotypes are suggested. Although this clustering is not so directly applicable to each subject, it can enable us to understand each type of common asthma natural causes. Asthma phenotyping is sometimes utilized as a predictor for the asthma prognosis. Researchers have not determined who would be at high risk for the adult onset severe asthma. When we classify asthmatic cases according to the developmental phase and the symptom severity, we may see a series of asthma progression to more severe ones. Based on the results, we can conclude some proportion of childhood asthma may progress and became an origin of adult onset severe asthmatics. Phenotyping by the asthma symptom and eosinophilic inflammation is also useful. In the atopic asthma, usually the symptom correlates well with the eosinophilic inflammation. However, there exists discrepancy between the degree of airway inflammation and the asthma symptom. Discordant symptoms may suggest the non-atopic nature of some asthma, and discordant eosinophilic inflammation also indicates the possibility of severe refractory eosinophilic asthma or other systemic conditions. Asthma onset is still very useful to cluster asthma phenotype. When it is collaborated with the marker for eosinophilic inflammation, it can collectively show various asthma phenotypes effectively. As you may see in this figure, childhood asthma is mainly allergic and the non-eosinophilic types are infection-related, air pollution-induced, or others. On the other hand, adult asthma comprises various asthma phenotypes, including the occupational asthma, aspirin-exacerbated asthma, obese asthma, and cigarette smoke-induced asthma. What variables can we use in the asthma phenotyping? When we redefine phenotype as the observable manifestation of diseases, all the observable parameters can compose determinants for asthma phenotyping. For example, allergic sensitization, asthma symptoms, lung functions, airway inflammation markers, exacerbation, medication response, and the eosinophil in the various specimens. Their combination may better explain the asthma phenotypes and help to predict the treatment outcome. There is a very famous report on the phenotyping of severe asthma. After applying several parameters, baseline FEV1, maximum FEV1, and age of onset is used for asthma phenotyping. As a result, 5 clusters were produced, and the pediatric types are characterized as one subgroup, the childhood onset severe asthma group. Let's look more into the pediatric phenotype of childhood onset severe asthma group. As you may see in this slide, earlier onset is associated with higher pre-bronchodilator lung function. They are characterized by eosinophilic airway inflammation, male predominance, sensitization to various antigens. Early onset childhood allergic asthma also can be divided into several subtypes. As you can see in the table, infancy onset severe asthma needs multiple controller medication and oral steroids. Moreover, it has many comorbid conditions. Whereas toddler to preschool onset severe allergic asthma has less frequent comorbidity and is more affected by the airflow limitation. Clinical features of severe asthma in children needs to be assessed earlier, and these features may give useful information. In the real world, we can easily see that treatment responses are not the same from each treatment. These figures show that there are people who respond differentially to either montelukast or fluticasone propionate than the other. Moreover, the degree of difference between the two traditional asthma medication is widely variable in the real practice. Then it is natural for us to ask by what means we can figure out the treatment response and determine the appropriate treatment option with confidence. The combinations of aeroallergen sensitization and blood eosinophil counts can be a good option, which is documented in a large-scale clinical trial. There have also been attempts to incorporate genetic information into the criteria for phenotypic determination. There exist many candidate genes that affect the asthma exacerbation or the treatment response. Among them, ADAM33 and ADRB2 are the first suggested target genes that explain genotype-specific differences. Genetic phenotypes are helpful in explaining differences in asthma susceptibility to the same environmental exposure and the different responsiveness to the same treatment. As genotypes are more causally related to the disease pathophysiology, they can provide valuable information in determining treatment modalities based on so-called endotypes. Let's move on to the main topic, the asthma endotypes. We can classify the patient population into several clusters based on the observable characteristics regardless of their direct relationship to a disease process. If we can classify disease subgroups according to a distinctive biological mechanism, it would be easier for us to choose the best suitable treatment options and to predict the response. It usually involves with the clinical characteristics, biomarkers, lung physiology, genetics, histopathology, epidemiology, or treatment response. Some researchers explain the cellular or molecular phenotypes rather than the clinical phenotypes are more suitable to the endotype definition. Let's look into the tentative severe asthma endotypes. The characteristics that we can observe from the severe asthmatic patients are asthma symptoms, airway inflammation, exacerbations, and low FEV1. Based on these characteristics, we can divide severe asthmatics into several clusters. Each cluster then shows interesting features, that is, early onset, obese, eosinophil dominant or neutrophilic. From these phenotypes, we can figure out several endotypes, that is, allergic Th2 asthma, ABPM, AERD with late onset asthma, obese and female dominant less eosinophilic asthma. Here we can see another example. From a clinical point of view, asthma onset is critically important to explain the nature of asthma. In addition, symptoms, exacerbations, and FEV1 may show differently according to phenotypes. When we incorporate the type of airway inflammation onto the various phenotypes, we may encounter these various asthma endotypes. Early onset allergic asthma is a representative childhood asthma phenotype, followed by the exercise-induced bronchoconstriction and infection or obesity-related asthma. Whereas the adult onset asthma comprises both Th2 and non-Th2 type. Among Th2 type asthma, there exists aspirin-exacerbated respiratory disease and the late onset eosinophilic asthma. On the other hand, non-Th2 asthma ranges from the obesity-related, smoking-associated neutrophilic, smooth muscle-mediated, pulsy granulocytic ones. This table shows the two representative endotypes, T2 high and non-T2. Their phenotypes, clinical characteristics, molecular mechanism, and biomarkers are listed. These two endotypes are critically different in terms of molecular mechanisms and their biomarkers. This table shows the difference in disease characteristics across the common asthma endotypes. When you look more into the API positive preschool feature, biomarkers of increased eosinophilia and elevated allergen-specific IgE, and the lung physiology of potential increased risk of loss of lung function are the key features of this endotype. It's one of the representative T2 dominant diseases. This figure brilliantly presents the relationship between the asthma endotypes. The main pathophysiology is allergy, which comprises the three early onset wheezing phenotypes, as well as the IgE high, interleukin 13 high, interleukin 5 high asthma, and ABPA and Th17 endotype. On the other hand, non-allergic asthma includes early transient wheeze, virus-induced wheeze, non-eosinophilic and neutrophilic endotype, part of the Th17 endotype, obesity-induced asthma, as well as the smoking-associated asthma. When we assess severe asthmatics, it is important to figure out to what endotype these subjects belong. The first and the most important step is to determine whether the endotype is derived by type 2 or non-type 2 pathway. Although many pediatric asthma is driven by type 2 mechanism, it may also be a complex of the interleukin 5, interleukin 4 and 13, systemic IgE, and local IgE pathways. Therefore, we should figure out what the main pathophysiologic driving mechanism is. As for the non-type 2 immune response driven endotype, it is also critical to grasp the main driving mechanism among the neutrophilic inflammation, Th17 pathway, barrier defect, and neurogenic inflammation. Some researchers have suggested a diagnostic algorithm of defining the proper endotype based on the appropriate biomarkers. I think this approach is useful, so we may consider assessing all these biomarkers in evaluating severe asthmatics. The endophenotype approach is valuable in a point it can suggest a brilliant way of treating the asthma. As you can see in this figure, standard of care is applied to most asthmatic subjects with no exacerbations. However, the subjects with frequent exacerbations needs to be clarified of their type of inflammation. For that purpose, biomarkers may play great roles and we can determine the most appropriate therapy, including the recently developed biologics. As you may see in this figure, many biologics that target each specific pathway have been developed or ongoing. So, all we need to do is to define the most probable pathways and the key player of their asthma. Still, it is unclear the difference between the phenotype and endotype. Both are determined by the clustering methods, but the endotype is more likely to be related to pathogenesis or the treatment responses. All factors that are involved in the asthma pathogenesis or the treatment responses can be a determinant factor for disease endotype. Anatomical factors, epithelial barriers, exposomes, microsome, metabolic pathways, genetic and epigenetic factors, as well as the involved innate and adaptive immune response can influence the disease endotypes. One researcher have named these types of specific endotypes as the inflammasome endotype, barrier endotype, theratype, regiotype, and corticosteroid responsive theratype. If we can cluster groups of subjects by analyzing the cytokine profile, it can also be new endotypes. In a recent report, there are reproducible immunologic endotypes regarding childhood asthma. From a cross-sectional asthma cohort that comprises steroid-naive, newly diagnosed mild to moderate asthmatics, cytokines from PBMC, specific IgE, and allergen component were assessed. Then cytokine clustering by unsupervised learning was performed. Finally, 3 major clusters were produced and replicated from the validation cohort. The new endotypes comprised 3 groups of subjects. First, the elevated food allergy and leukocytes and decreased lung function in the younger children, which is green. Second, increased ratio for sensitization to apple or birch and decreased lung functions, which is red. Finally, the blue one would be the others with increased prevalence of rhinoconjunctivitis and sensitization to timothy and dust mites. As you may see in the figure A, a subset of study population was divided into the 3 immunologic endotypes after clustering cytokines of all training subsets. In figure B, the results were well validated from the other group of subjects by cytokine clustering. Each specific group presented a distinct identifiable clinical feature. Unfortunately, I could not find the phenotype or endotype data specific for the Asian population. For Korean pediatric asthma, neither we have any available data regarding the asthma endotype, but I can briefly introduce the phenotype suggested from the Korean childhood asthma study cohort. Recently, in South Korea, a prospective nationwide registry on pediatric asthma has been launched and is now ongoing to collect data. The study name is KAS, K-A-S, which initially aimed to collect clinical features and determinants over thousands of Korean asthmatic children, and to evaluate and validate risk factors of asthma exacerbation from the population. Here are the clinical characteristics of KAS participants. Since the authors limited their analysis to those with sufficient follow-up data, the total numbers of population is around 670. 2/3 are boys. Large proportion of subjects has current AR, but not the current AD. Around half began to show asthma symptoms before 6. 3/4 of population had mild asthma, while only few had severe persistent one. Those who had atopy defined by 1 or more positive reaction to skin prick test were almost 75%. 4 phenotypes were derived from the unbiased latent cluster analysis. Cluster 3 showed low proportion of male subjects, relatively later distribution of asthma onset age, and relatively higher BMI. Cluster 4 had relatively low number of atopic subjects when being compared to other clusters. Cluster 1 and 2 are similar except for the lower proportion of subjects with atopic dermatitis in the cluster 1. Based on these clinical characteristics, we can now define the characteristics of each cluster as follows. The male dominant atopic asthma, early onset atopic asthma with atopic dermatitis, puberty onset female dominant atopic asthma, and the early onset less atopic asthma. Although we have not evaluated various biomarkers yet, we have followed up the lung function and FeNO. We found that lung function and FeNO usually does not change significantly over time, and thus 4 asthma groups remain largely unchanged. Please keep your eyes on the main 3 determinants of the Korean asthma phenotypes. Onset timing is important. Most but one showed early onset of asthma. Degree of atopy is also important. In pediatric asthma, there is one early onset, less atopic asthma group. Finally, presence of current atopic dermatitis is also important. These results correspond well with other previous studies. After we have divided the heterogeneous population into 4 clusters, we can figure out that these 4 asthma clusters show a couple of discrepant asthma-related outcomes. Cluster 2, early onset atopic asthma with AD group, had intermittent asthma with no control medication, whereas the class 3, puberty onset female dominant atopic asthma, higher level of asthma medications. While cluster 1 and 2 comprised most of pediatric asthma characteristics, cluster 3 presented lower lung function at all aspects in the beginning and at FVC in the 6-month follow-up visit. The results implicate that most pediatric asthma is the early onset atopic profile, but in an adolescent stage, there emerges a peculiar group of children, female dominant and atopic. We may apply a different strategy to deal with this type of asthma in our clinical practice. Some determinants were found to increase the risk of moderate to severe asthma. Late onset and the recent exposure to tobacco smoking as well as the dog ownership while being sensitized elevated the risk of getting more severe asthma. But no information is available on what factors can lead us to predict subjects have better prognosis. Now it is time to summarize. Asthma is an umbrella term of diagnosis, so we need to categorize into several subtypes. Phenotype is very practical to understand the current situation and to predict future prognosis. If we can classify asthma into subtypes by the more pathophysiologic criterion, in other words, into the more appropriate endotypes, we may decide the more precise and effective therapeutic options with more confidence. This figure shows the change in the approach to the patient treatment. Traditionally, we first apply all the same standard management to all the heterogeneous set of patients. Then you apply the Plan B management to those with treatment failure. In the same way, we then apply the Plan C and Plan D. However, these days we are recommended to stratify the patient population first, then to decide the treatment options apparently suitable for the subset of population, which now we call a precision medicine. For that purpose, it is essential to make an appropriate endotyping first. I admit it is not easy, but eventually we can perform a proper endotyping by we perform a proper clinical, cellular, and molecular phenotyping with variables regarding the clinical characteristics, biomarkers, lung pathophysiology, genetics, histopathology, epidemiology, and treatment response. As we may figure out from this diagram derived from the childhood asthma prevention study, the proportion of childhood asthma phenotypes may change across the time, which means some populations changes their phenotype from one to the other. Then we can be curious what sort of population would persist their phenotypes while the others not. This is a diagram showing the natural course of pediatric asthma. At each time point, we do not know whether the current asthma would go away or persist to the adulthood, especially when subjects had asthma at the first few years of life or in the adolescent periods. I do believe defining the asthma endotype will clarify this issue of prognosis for the current asthma. This is what I have prepared. Thank you for your attention. If you have any question, just email me described as below. Thank you.